So we're going to move on to actually talking about gastric cancer. The first module is on pathophysiology. I'd like to frame this with just a clinical vignette. We'll maybe go back to this a few times during the presentation. So this is a 66-year-old man who has a 6-month history of dyspepsia without dysphagia or weight loss. Although his symptoms previously responded to antacids, over-the-counter H2 receptor antagonists, these medications have been ineffective for the last 2 months. His physical exam and complete blood count are normal. So which of the following is the most appropriate next step in the management of this patient? Either testing for H.Pylori, a CT scan of the abdomen, upper endoscopy, radionuclide gastric emptying study, that's a nuclear medicine test, or doing an 8-week trial of a proton pump inhibitor. And I'll let you think about that. So the answer for this one is an upper endoscopy, and we'll talk about why that is. My understanding is that though you may not have that immediately available right where you are, that perhaps that can be referred to, but we can certainly talk about that at the end. So in terms of gastric cancer epidemiology, gastric cancer is actually the 4th leading cause of new cancer cases worldwide. So it is a really important high health burden cancer across the world, although in the United States, it's actually much less common. And worldwide, it's the 2nd leading cause of cancer-related deaths. Gastric cancer is probably the most common in some of the Asian and East Asian countries, as opposed to more Western countries, and that we'll talk about why that is. This is just a map showing the global incidence of cancer. The legend shows incidence per 100,000 cases. The dark green are areas that are really high incidence regions. So you can see that in Eastern Europe and the large majority of Asian countries have very high incidence. If we were to look at Africa, it is a little bit mixed, but the very light green actually shows that there's no data. And we'll talk a little bit about why that is and why perhaps gastric cancer may be more common than is appreciated. This is a graph to show global patterns of gastric cancer incidence by country. On the left are males and on the right is females, and it's color-coded with the legend along the bottom. African countries are in sort of a purpley pink color. The most common of 9 per 100,000, you can see here, is Zimbabwe. And that's for males. And then for females in Uganda at about 7 per 100,000 cases diagnosed per year. All right, let's talk a little bit about how we classify stomach cancer. So in the picture on the left, you can see a picture of the stomach and the esophagus. Esophageal and GE junction cancers are right next to the stomach. They are classified by something called the Siewert classification of type 1, type 2, and type 3. Type 1 is really here just at the lower portion of the esophagus. Type 2 includes the GE junction. And type 3 includes anything from just below the GE junction to the top part of the stomach. Stomach cancer formally then just includes the body and the antrum. Epidemiology patterns are really shifting more in developed countries, including the United States. It's much more common to see tumors in this GE junction area than in the more distal part of the stomach. And adenocarcinoma is quite a bit more common nowadays than squamous cell carcinoma. Squamous we would generally only see in the esophagus. Adenocarcinoma is in the GE junction and further down into the stomach. Let's talk a little bit about risk factors. So there are both risk factors that are modifiable and ones that are not. So in terms of nutritional risk factors, low fat or protein consumption can increase risk, as can salted meat or fish, and high nitrate consumption. Medical risk factors include prior gastric surgery, H. pylori infection, which increases the risk for gastric cancer twofold, and gastric atrophy or gastritis. Environmental risk factors include poor food preparation, such as smoked foods. That's actually quite common in some of the Asian countries. Lack of refrigeration, poor drinking water or well water, occupation, such as workers in rubber, coal, and metal, and smoking increased risks by 1.6 times, and then low socioeconomic class, which probably speaks more to access to care. This is a map of H. pylori infection, and I thought this was, I don't have these exactly overlaid in terms of the incidence of gastric cancer, but if you recall that other map, those do overlay quite nicely. So the purple and blue color show reported prevalence of H. pylori infection that is quite high. So in Eastern Europe, China, Japan, India, some of the countries in Africa are listed here, Libya, Egypt, and these are, because this is an infectious risk factor, it's potentially modifiable. Much of Africa is just unknown. I think that the rates of H. pylori infection are not well described. Because this is perhaps relevant to you and your patient population, H. pylori infection is felt to be quite common and very prevalent infection in much of Africa. The indications for testing include patients who have a duodenal ulcer, gastric ulcer, atrophic gastritis, gastric malt lymphoma, following resection of an early gastric cancer, or uninvestigated dyspepsia in areas with a high prevalence, which would very likely be your patient population. Testing options include, there are a variety, blood test, breath test, stool test, and biopsy by esophagogastroduodenoscopy, so EGD. And then treatment is actually quite simple. It is a 3-drug treatment of clarithromycin, amoxicillin, and a proton and pump inhibitor for about 14 days, though I have seen some studies look at 7 days. Okay, so that's the first section on the pathophysiology of gastric cancer.